Hey everyone, it's Gary Brons here from the National Kidney Foundation. I'm happy to welcome you to another edition of the National Kidney Foundation's NKF Live series. Today we'll be discussing a topic, I'm going to try to pronounce this correctly. This is autosomal dominant polycystic kidney disease, or for the purpose of the rest of this program, ADPKD. My understanding is that ADPKD is a sense of cysts that form on the kidneys, and they essentially detract from the kidneys functioning normally. I'm going to confirm that in a second because I'm lucky today to be joined by a couple of experts in the field. One of them is Dr. Neera Dahl. Dr. Dahl is a senior associate consultant at the Mayo Clinic. She specializes in working with kidney disease patients. So thanks for joining us today, Dr. Dahl.
It's my pleasure.
Also lucky to be joined today by Carrie Maxwell. Carrie is a person who is living with ADPKD. She has a family history of the disease. Carrie's been a member of the National Kidney Foundation's Kidney Advocacy Committee. She is highly involved in patient education and promoting early detection and clinical research. Thanks for joining us, Carrie.
Thanks for having me.
You're welcome. All right, so just to kick this off, Dr. Dahl, help us try to understand what ADPKD is. And there's another term that's out there that I heard, which is called total kidney volume. And maybe if you can explain that and sort of how these two things are interconnected.
Sure. So starting at the beginning, so ADPKD is a genetic kidney disease. It's an inherited kidney disease and typically caused by a defect in one of two genes called PKD1 and PKD2. And these encode for proteins that are very important in maintaining the normal structure of the kidney. So when you're missing one of these proteins, what happens is there are cysts that form, and they start forming at as soon as the baby is starting to develop, but they form throughout life. And the cysts get bigger and bigger, and eventually there's scarring around those cysts in the kidneys, and that leads to loss of kidney function in about 60% of people by a fairly early age, by the 60s. And so what you mentioned, Gary, the other term you mentioned was total kidney volume. This is a way for us to look at progression and follow who with PKD is at highest risk of developing loss of kidney function. So well before there's loss of kidney function, the cysts are getting bigger and bigger, the kidneys are getting bigger and bigger, but the kidney function is still preserved. And so the clue that tells us, hey, this person is at risk of losing kidney function is how large that kidney is. And we measure that by measuring something called total kidney volume, where we basically look at the size of the right and the left kidneys and then add those together, adjust them for height and adjust them for age. And that gives us a diagnostic tool to determine progression in this disease, PKD.
My understanding is that this is a hereditary issue. Is that correct?
Yes, that's right. This is typically about 85% of the time people know that they are at risk for the disease because one of their parents may have the disease. And it's just one parent needs to have it. It's autosomal dominant. That's what the first part means. But in about 15% of cases, maybe more, there's no family history. So we make the diagnosis for the first time when we look at the patient's imaging.
So it's got to start somewhere.
Yeah.
Yeah. All right. So, Carrie, that leads me to you. Sort of, I know you probably know a lot of what we're talking about here because you've been through this. So, why don't you share your story with the folks that are watching and your experience with ADPKD and total kidney volume and all of that stuff?
Sure. So yes, it's a family affair where it's concerned in our family. My father inherited the disease from his mother, and all three of his children with my mom have ADPKD. So my two siblings and my oldest daughter so far is diagnosed of my three children, and so I knowing this, my parents knew to have us kids looked at if they suspected anything that was going on with us might be connected to ADPKD. So it was an ultrasound when I was around the age of 9 or 10 that showed I already had cysts in my kidneys. And so it's in that way that having a hereditary disease has really helped at least our family know ahead of time that we have this as part of something that may happen to us as we grow older. And so we've been educated and we've been aware of what to watch out for as far as our blood pressure, our diet, taking care of ourselves. So I learned that I had the disease when I was 18 and an adult. And it wasn't a complete surprise, right? Because I knew I had the 50-50 chance of having it. Um, and then just, my kidneys really kind of began to show signs of deterioration in my mid 30s. I went on high blood pressure medication. I entered a clinical trial to help address what was going on with my progression of ADPKD. And that brings us up to today.
Thank you. Yeah, it sounds hugely important that you knew that there was a family history here and to sort of monitor it as you were getting older, right?
Absolutely. And I think the early detection part is really key. We hear so many times about people crashing into dialysis, and I never wanted that to be my story. And so I really used the opportunity of what my dad went through to propel me to get as much information as I could about what was happening to me and what could potentially happen to my kids.
So Dr. Dahl, if I think a lot of people that are watching this, they probably want to know that if your total kidney volume is worsening or your kidney function's declining, what can you do?
Yeah, so that's a great question, and that's really the first thing we talk about when we see people. And I think Carrie mentioned a lot of really important things, right? So the first conversations are about managing blood pressure, making sure people are on the right diet, eating the right kinds of things to help preserve kidney function. We talk about weight. We know that having extra body weight can put a strain on the kidneys, and so we talk a lot about lifestyle and diet initially. Blood pressure control is very important. So the people who are at highest risk, we're targeting a blood pressure target that's fairly aggressive at 110/75. And there are some medications that we think are in particular very good for treating blood pressure and PKD. And typically those the classes of those are called either an ACE inhibitor or an angiotensin receptor blocker. And then for those people who are at highest risk of progression, so people in that have the total kidney volumes that put them into Mayo 1C, 1D, or 1E, those are the imaging classifications based on total kidney volume. Those patients are then eligible for a new medication called tolvaptan. Tolvaptan inhibits the effect of a hormone called vasopressin, and we think vasopressin is very important in the progression in ADPKD. So by blocking that, there's a benefit to patients with ADPKD for reducing risk of progression, reducing the time to progression, increasing the time to progression. Sorry.
Right. Thank you. Carrie, I wanted to ask you about quality of life, right? You've been living with this for a long time now. Has it affected your quality of life? And are there things that you're doing to help your quality of life? People talk about, first of all, you got to go to work. A lot of people like to go to the gym, go out to dinner with friends and family, all of that kind of stuff. Has it affected you in any way? And what have you done?
I think that's something that is very different across the spectrum of patients. I personally, feel fortunate that my quality of life hasn't been terribly impacted. At least that's my particular view of how things are going. Yes, I take two medications, and initially, when you begin taking a medication, there's a bit of a an emotional adjustment, I think, because now you go from not really realizing or thinking about your kidney disease to every day when you take your medication, you're kind of thinking about it. So there's a little bit of an adjustment there that I've noticed and talked to other patients about over the years. Um, but I'm pretty active. I golf. I try to stay active and go to the gym when I can, when I feel up to it. I work a full-time job. I've got 3 kids, a dog. I'm living a pretty typical life at this point. When my kidney function started to decline after the birth of my third child, I started researching, what can I do to slow this down, because I still want many more years until, I need some other intervention like dialysis or a transplant. And that's how I found out about tolvaptan. And that's a treatment I'm still benefiting from today.
Great. So speaking of tolvaptan, are there other treatments out there, Dr. Dahl? Are there other things that people can do?
So there are clinical trials for those people at highest risk who don't tolerate tolvaptan or don't want to start tolvaptan. There are some side effects. So when you block vasopressin, you block the ability of the kidney to make a concentrated urine. And when you do that, it means that you have to drink a lot and you're urinating a lot. And so sometimes that can be really disruptive for people, depending on what their lifestyles are. So patients who, for example, one was a waitress or one worked in an Amazon warehouse, and they just couldn't get the time to be able to be able to tolerate that side effect. And so, for people that really can't, or the tolvaptan is not a good fit, there are clinical trials that are ongoing, and there are a lot of different clinical trials right now. And the way the trials work is you're either on drug or placebo, and then we look at that data when the trial is finished to see if those drugs are going to be effective in also helping to slow down the progression in ADPKD.
All right, great. Well, I'm glad you mentioned the clinical trials. And actually, for the people that are watching, the National Kidney Foundation has a page on our website dedicated to clinical trials. So you can go there. It will tell you how to get involved, what's out there, what's available. You can also always call us at the NKF at 855 NKF Cares or email nkfcares@kidney.org. And I think that we'll be showing that information across the screen throughout this presentation. I was going to ask you, Kara, you and I have spoken about this before in the past, but the importance of working with your healthcare team. And, a lot of people think you just make a doctor's appointment, you go to the doctor, they're going to take care of it. But can you talk a little bit about the importance of working with your healthcare team and what that team is essentially?
Absolutely. It's really critical to stay close to a nephrologist that you trust. And, if you start a relationship with a nephrologist and you're really not feeling it, it's okay to go and try to find another. But make sure it's someone that you can confide in, because there are a lot of things you're going to experience that you will need to be really honest about. And it's a long-term relationship. It's going to be for the rest of your life. So it's really important to start that off strong and find someone. You can, ask other patients for referrals. I think that's a great source to get, the personal experience. But as far as working with them, it's really an open dialogue that is ongoing. At this stage in my kidney disease progression, I'm emailing with my provider between visits if I have a question that's not urgent. Talking with her about just dietary strategies and just other things that I think might help me, and I want her advice on it, because at this point we've built a long-term relationship, and I trust her. I trust her opinion, and I wouldn't want to do anything to hurt myself, with anything, any kind of intervention that I might want to try to help myself along. So. Um, But I think, an important aspect that we don't talk about too much, is just being open about how all of this impacts us mentally. And so that's a thing that I've been more open recently about with my nephrologist. I know it's not technically her area of expertise, but it's something I want her to be aware of, because I know she's compassionate and she sees a lot of kidney disease patients, but I know she personally isn't living with kidney disease or PKD. So I want her to have a sense of what it's like to go through what a kidney disease patient is going through and how that impacts our family, and what we're kind of looking forward to as our disease progresses. So it's good to have that open dialogue and just get that support where you can get it.
And you always talk about advocacy, but really advocating for yourself is the most important thing. You've got to ask the questions. It's okay if it's not the right person; they're there to help, and hopefully they can point you in the right direction, right?
Absolutely. I think it's our duty to question the things that we're being asked to do. If we're being asked to take a medication or have a particular test done, it's really okay to say, well, can you tell me why? Not as a adversarial way, why. It's more of just, I want to understand why this is being asked of me. Help me understand how this will inform you and it will inform my care. Help me understand how this will impact me and what we do going forward.
Yeah. Well, I guess we're a little ways in here, and what I'd like to do now is for the folks that are watching at home, I want to take a couple of minutes to just look at some of the questions that they've been asking online. I just want to remind the folks that are watching this that if you have questions on this subject or other subjects related to kidney disease, you can post them in the comments section. If we run out of time, we don't get to your question today, just know that all the questions will be addressed over the course of the next few days on the NKF's web pages after this program. So let's see what we got here. Here is a question from Brad in Sarasota, Florida. Brad is asking, if my total kidney volume is not great, what does this mean in terms of the progression of my disease? So Dr. Dahl, you want to take a shot at that one?
Sure, I'd love to. So total kidney volume, the way we look at it now is we measure the total kidney volume, and we do this by looking either at an MRI or a CT scan of the kidneys, or sometimes we can do this with ultrasound as well, but we get some kind of imaging of the kidneys, look at what the kidney sizes are, and calculate a total kidney volume, and then adjust that for the patient's height. So we know that taller patients have bigger kidneys, and then also adjust it for the patient's age, because we know as patients age with PKD, the kidneys will get larger. So the three high risk classifications are 1C, 1D, and 1E. The other two, 1A and 1B, are considered low risk classifications. And so once we know that you're in 1C, for example, we can predict, like, hey, we think your kidneys are going to grow at this rate because you're 1C. Or once you're 1D, we can say, no, they're going to grow a little bit faster because you're in this higher risk category of 1D. And the same like 1E, those patients have often very, very large kidneys by the time they reach end stage kidney disease. So um, we are watching that. At some point, there's a tipping point, like Carrie described after her third baby, where in addition to the kidneys getting bigger, the kidney function starts to decline. And so then we're not looking at risk of progression, which is what the total kidney volume is telling us. We're actually looking at progression when we see loss of kidney function. So if you look at what your GFR is and notice that your GFR is going down, then that's a sign that you're starting to lose kidney function. And that, once that sort of you hit that tipping point and the numbers start to decline, sometimes that decline can be very, very rapid. So we're really trying to initiate treatment up here, like in that flat part of the curve before there's loss of kidney function. That's why total kidney volume is so important, because when the kidney function is normal, we can look at the kidney size and say, hey, we think you're at risk, even though the kidney function is normal right now.
Thank you. Here's another question that came in from Kirsten in Fairfield, Connecticut. Kirsten wants to know, she says, I've heard of something called predicting renal outcomes in polycystic kidney disease. So she types it out, Pro PKD. It's a score that sounds like it's a predictive score. Can you describe that a little bit?
Yes. So Pro PKD is another risk assessment tool in PKD. So we talked about total kidney volume giving us this sort of before kidney function declines, telling us who's at risk. The other way of saying who's at risk is looking at this Pro PKD score. So this is based on genotype. What's the gene that's causing your PKD? Is it PKD1 or PKD2? We know that PKD1 variants, PKD1 mutations, particularly those PKD1 variants that don't cause that completely knock out the protein. So there's no full length protein made. They're called truncating mutations. Those mutations have the most severe phenotype. And then there are PKD1 mutations where there is some protein made, but it's abnormal. And those are PKD non-truncating, PKD1 non-truncating mutations are that second level of risk. And then the third is PKD2. And people with PKD2 mutations, even though they have PKD, they tend to have end stage kidney disease later in their 70s. So we look at genotype, whether someone is male or female, because we know that males progress faster with PKD, whether they had high blood pressure or a urologic event like a kidney stone or an infection in the kidney before the age of 35. So there are two clinical questions about hypertension and urologic event, the sex of the patient, and then the genotype is what's in Pro PKD score.
Okay, fantastic. Thank you. Let's see. We've got a question from Carol in Brooklyn, New York. Carol wants to know, for Carrie, how did you find out that you had PKD? How was it diagnosed? And what are your suggestions to viewers about getting the best care? It's quite a mouthful there, but if you don't mind going through it, Carrie.
It's what's on everyone's mind, right? So, because my father had end stage renal disease when I was quite young and went through dialysis and a transplant all before I was 10 years old, my parents knew that it was a hereditary disease, and they knew that all three of their children would be at risk. Some things were kind of going on with me that my mom said, hey, let's just get you checked out. And so via ultrasound, that is when I was diagnosed at 9 or 10 years old. And then, there was no further reason for my parents to talk with me about that at that time. I was healthy and not experiencing any side effects or need for any intervention. So they told me when I was 18 years old. And I've lived over half my life with the knowledge that I have it. And of course, later on, my younger two siblings were diagnosed as well. I'm the farthest progressed of all three. I'm not sure why that is, but I am the oldest as well. Um, and I think for what to do when you're diagnosed is just really going back to the care team. Establish who that care team is going to be. It's a nephrologist you trust. And then I think it's also, the team around that, your family, your friends, some people in your life that you can confide in about what's going on, and you'll need that support as things change for you with your health. I think also just, being willing to talk to your doctor about what kind of interventions or treatments might be right for you. It's always the best idea to get their buy-in first, and they will help guide you through what medications you should be taking, what foods or beverages you can, try to avoid, and what foods and beverages will be good for you to really lean into for a good PKD diet.
Thank you. Um, so it looks like there's a lot of questions coming in about tolvaptan. You mentioned that earlier, Dr. Dahl, and I'm just going to kind of lump a bunch of these together and see if you can help us understand what's going on here. So it's somebody's asking about what tolvaptan is, what are some of the side effects. Somebody else is asking, are there drug-drug interactions or food-drug interactions related to tolvaptan? Somebody else is talking about its effects on the liver or other organs. You want to try to make heads or tails of this stuff and sort of explain tolvaptan to the folks out there and what's going on?
Yeah, so tolvaptan is a medication. It's a specific vasopressin receptor antagonist. So it blocks the effect of this hormone called vasopressin. And vasopressin is important in helping make concentrated urine. But we think also that vasopressin is important in high blood pressure. And so knocking out the effect of that hormone seems to be particularly important in treating ADPKD and in decreasing cyst size and then helping retain kidney function. So that's the benefit of tolvaptan. All of those other questions are really, really important. And we have a very long conversation before we start patients on tolvaptan. So the first is, what are the side effects? So the first and most important side effect is that because you're no longer making a concentrated urine, you need to drink a lot and you will urinate very frequently. And so that's a major side effect that takes people a little while to adjust to. So Carrie is a beautiful example of someone who's been on the drug for a while and now is like, she's built her lifestyle around it. She's adjusted to it. The other is we worry that tolvaptan can cause liver injury, and there's a mandated, it's called a REMS program, where before we start a patient on the drug, we check their liver function tests. That's a blood test. And then at 2 weeks, and then at 4 weeks, and then monthly thereafter for the first 18 months, we're checking labs to make sure there's no signs of liver toxicity. And then after the 18-month mark, we check every 3 months, because most of the cases of liver injury that we're seeing in the trials happen very early. And now that people have been on tolvaptan and it's been approved and we've been following the patients in the REMS, we've seen that actually by following it that way, it's a fairly safe medication, because as soon as we see the liver function tests start to go up, we stop the drug, and sometimes we'll stop it and then restart it later safely. Sometimes we'll stop it altogether. So we're being very, very careful. And when someone is on tolvaptan, they're getting very, very close follow-up, because we need to be in communication with the patient taking tolvaptan to make sure that they are getting the medications, they're taking it safely, we're getting the blood work done, and so that they're doing okay. And so often there are a lot of additional touch points that happen with our care team, so with our nurse practitioner, with our nurse, with the patient, to make sure everything is going smoothly in that process. And then you asked about drug-drug interactions. So this is a drug that does interact with other drugs. And what we tell people is, before they start a new drug, to let us know what that drug is, and so we can give them some sense of it. I think there's for example, an antibiotic that's fairly commonly prescribed that can increase the levels of tolvaptan. And so we want to be careful about that. We look at all the medications the patient is on before they start tolvaptan, to make sure that there isn't a bad interaction that's likely to manifest. So we're looking at all of those things very, very carefully before we start. And then there are a few foods that we say to avoid. So grapefruit turns out to interact with a lot of things, and so like a lot of different medications, we say to avoid grapefruit and Seville oranges and a few foods, but not really a major food restriction.
Okay. All right. Thank you. Carrie, this one is for you. This is from Gail in Hoboken, New Jersey. And she said, first of all, thank you so much for sharing your story. She really appreciates it. She also wanted to know if there are some lifestyle changes that you've made that help slow the progression of kidney disease.
Well, I believe there are some out there that would be great to talk to your doctor about. There's a lot of information out there right now about various diets and things like that. But it's really important to get your doctor's buy-in before making any kind of change like that. Unfortunately, for me, a lot of that information has come out in the last year or so, and I'm at the point in my progression where there's not a lot I can really do to help things go back up. And so my goal right now is just to stabilize and try to hang on to these last few um, percentage points of function before I need a different intervention. So for me, it's just really being mindful of my diet. I eat a pretty good diet. I'm on tolvaptan, so I drink a lot of water. I really just eat a lot of fruits and vegetables. I don't eat a lot of red meat. I'm pretty decent with, caffeine, other things like that. I think it's just general things that would be good for just about anybody. Just keep a healthy diet, eat a lot of fruits and vegetables, stay active as much as you can, right? Keep your weight, healthy in a healthy range. And these are all things that my nephrologist and I talk about each time. And she will look at my lab values and say, hey, it looks like this number's creeping up a little bit. What's going on here in your diet? Anything that might be impacting this? And again, it's an open conversation that we're having every 3 months.
Fantastic. Thank you for sharing that, Carrie. And I think we've been posting the number on the page here, but 855 NKF cares. You know, advocacy, nutrition, hugely important. Exercise, all of that stuff. You can get a ton of information about that, about the clinical trials that we spoke of earlier from our website. Unfortunately, we've run out of time to talk here, but in case we didn't get around to answering your questions today, just know that you can check back on the NKF's Facebook pages. We're going to be posting answers throughout the coming days. All the questions will be addressed. I want to thank our sponsor, Otsuka, for their generous support of making this program possible. And I would especially like to thank Carrie and Dr. Dahl for joining us today and helping make sense of what I know can be a very difficult subject for so many people. So thank you so much, guys.
Thank you. It's been a pleasure.
Thanks,
So
Gary.
now, on behalf of the National Kidney Foundation, I would like to wish you all good health.